all yours.
I heard a talk by Sumit, I think a week or two ago, and I've done that talk. He sent me all his slides. He was kind enough to send his slides. I have to make a but I am afraid I have dumbed it down completely because in my old age I can't understand most of what the talk is about. But so it's a very dumbed down version. If you want the real version, next time ask him to come and speak on. So personalized medicine in the ICU, one size does not fit all. So actually, Hippocrates first said that actually disease was a result of multiple factors, including lifestyle, environmental forces, and diet. And accordingly, as these are unique for every individual, treatment should be focused on the individual. He stated that because the organism acts as one, it should be treated as one, and not as individual parts of a bigger system. And curiously, the one person who actually followed this principle was the person that we like to deride, Samuel Hahnemann, the father of homeopathy, actually. All of us say Ayush and all that, we deride them, but he's the person who said that basically, actually, he basically rebelled against, there was a generalized of bloodletting, everybody was, one size fit on everybody was, a leech was put on everybody was sick, and so he actually rebelled against that system and actually propounded the theory of homeopathy. Of course, I'm not saying there are a lot of deficiencies in the system, because the personalized, people now saying homeopathy is actually modern personalized medicine, but of course in personalized medicine we use advancements in genomics, biomarkers, etc. to tailor disease, whereas homeopathy derives on a lot of similars. But the homeopaths now say this is personalized nanomedicine, something that's not been proven yet, but we don't know how the future will be, because they keep diluting it so much that ultimately there's nothing left in the solution, but they say nanoparticles are still left. That is their defense. I don't know. I think we should have an open mind, not necessarily everything that we do is right and Ayush is completely wrong. We need to have an open mind. If it shows it works, maybe it does. So, and I think actually in medicine, in internal medicine, the only way that really was personalized medicine was in leprosy. In leprosy, you actually look at the patient, you look at his response, and then you decide what therapy. There's no one size fits all for leprosy, depending on the, whether it is, possibacilly, multiple bacilli, what is his response, good immune system, strong response, variable, deficient, treatment is different. So this was from many years, many years ago. One of them was Dharmendra, now of course is in the other Dharmendra. So there was a Dharmendra for leprosy who was one of the people who was part of this whole thing. So I think that's the only thing that I know in medicine where we make it a little more personalized. Otherwise, not too much in medicine. In the ICU, we are doing a bit of personalized medicine, nothing much, But I think the problem with our trials is that, so quite often we tend to throw out what's called the baby with the bathwater, which means you throw out something that is useless. Along with that, you throw something that is useful as well. So that's called throwing out the baby with the bathwater. And many of the trials that we have done have resulted in this throwing out the baby with the bathwater, because people have not taken into consideration the heterogeneity of effect, the personalized, different people are different when they do conducted large case trials, which is why we have a lot of negative trials in critical care, and a lot of treatments which were supposed to be potentially useful have been thrown out. Now, Zygris, I'm not a big fan of Zygris at all. I agree that most of the situations probably it was not useful, and probably but I think when they said that it should be removed from the market, I don't think that was right, because there were certain situations which actually worked dramatically. Clearly, patients with purpura fulminans, there was no question that it worked dramatically. I know there's a very small subset, but in them it really worked dramatically. So when you throw away Zygris, which was potentially life-saving in patients with purpura fulminans, fulminant meningococcemia, severe pneumonia, but once your study showed that it didn't work in a heterogeneous group of patients, that whole drug was thrown out. So that I don't think is right. Another study which I think is starches, again controversial. I'm stepping into dangerous territory. Everybody after this study, two studies said starches are out of the market, but studies have shown that actually if you look at the study, the Christmas and the Crystal trial, which shows a good outcome with starch, they were initiated early on in the process of sepsis in people who are actually relatively volume deficient. The other studies, Chest and YSEP, and the other study from Scandinavia, all done a little later on in the day when they were not reasonably well resuscitated, and they were negative studies. But people didn't look at that, and they said starches are dangerous. They stopped it completely. Now people, you just can't use a starch, and we have to use albumin. Albumin is much more expensive. So I think in certain situations, no renal dysfunction, probably a bleeding patient, post-op patient, there is still a role of starch. So you need to individualize. You can't make a blanket decision that no starch is completely banned in the ICU. There are situations where you need to, but you need to know whom to use it on. I'm not saying you should use it on everybody, but you need to use it on. Another thing that has been thrown out again is IABP, Swan Gans, everything has been thrown out. But because studies showed that, they were useful in a broad group of patients. Again, like I said, but IABP also look at the study, younger patients had good outcomes, less than 50. Patients with antiretroviral infarcts had good outcomes. Patients with not such a low BP had good outcomes with IABP. So again, throwing out everything is not necessarily the right thing, but the reason I'm saying is essentially is, now again, the other things also, sometimes we blindly follow a therapy because one study has shown everybody gets, after the recovery trial, everybody with COVID got steroids. That became now, on the one hand we threw out certain drugs, on the other hand we blindly accepted a particular drug because one study showed. But surely, even in a study, there are some patients who would be harmed with the steroid. Not everybody who's on steroids with COVID does well. But because maybe in a majority of patients the study are benefited, the ones who in harm are outweighed, so therefore the study comes positive. But still, ideally we need to further identify patients in whom the actual, we further need to further classify. So if you look at these two studies about glucocorticoids in COVID, they looked at CRP. So the patients who had a high CRP and got steroids did well. But the patients who had a low CRP and got steroids did badly. So it's not that everybody, again, COVID. So ideally you have to, maybe in the study, the patients who were hypoinflammatory, low CRP were underrepresented. Therefore, that was a positive study. But in actual, when you're at the bedside, before blindly giving, any therapy that you think is work to everybody, I think you need to reflect a bit. In my ICU, sometimes I have a neutropenic patient, 80-year-old, he gets steroid because in septic shock, but this patient is 0 neutrophil count, he's 80-year-old. Just because in septic shock and septic site guidelines say that you need to give steroids, I ask him, you ask yourself, do you really think this patient needs steroids? He's already 0 neutrophils, but still blindly because so I think we need to reflect, don't blindly follow guidelines. You need to reflect on, certain situations where you need to overthrow the guidelines. Like somebody said, guidelines are for dummies. I mean, we are all past that stage. You need to know how to interpret the guidelines in the light of your patient load. And then there's another study, which again, high PEEP versus low PEEP. This showed one example of variability. The study by Gattinoni showed that not everybody with ARDS has the same amount of, recruitability. Some patients have great amount of recruitability, some patients don't. And the ones who have recruitable lung respond to high PEEP. The ones who don't have recruitable lung don't respond to high PEEP. But unfortunately, at the bedside, it's difficult to know who is recruitable lung, who has not. There are different methods. Again, this is one idea of personalized care. The ones you try and find out who has recruitable lung, there you can use a higher PEEP, the others you don't. But at the moment, the best method of finding out this is not yet very clear. Now, two other studies. This is the hydrocodone severe community acquired pneumonia, recent study which showed that steroids are beneficial in community acquired pneumonia. Just a few months before that, there was a study from America, the study which showed steroids had no effect in community acquired pneumonia. I mean, were not beneficial at all. So again, what was the main difference between the two patients? The CRP was much higher in the second study, the positive study. There were more women in the first study was, the second study, the negative study was a veterans army study, almost predominantly ex-army men, so 95% males, whereas in the CRICSEP study, the positive study, a lot of 60% males, or 40% or 30% were females, and women respond better to steroids than men. So higher CRP, steroids started much earlier. So so if you're going to, so if I start steroids now in CAB, I would probably start it much earlier, probably definitely a lower threshold in women, and I do CRPs. I'm not saying, this is, like I said, again, my method, but I don't use blindly steroids to everybody just because of surviving sepsis guidelines. Somebody else says that if the CRP is high, I might give one dose, but before I'd send the CRP off, give one dose, but if the CRP comes back normal, I'd probably stop the steroids. That's just my way. I'm not saying necessarily the right way, but that's how it is. So that's the sort of basic part of my talk. Now, why does this happen? Because this is what happens in studies, is so-called heterogeneity of treatment effect. That's what I meant. Like in a particular study, overall, yes, the study may be positive or negative, but within that study, there's a subgroup of patients where that drug does good, there's a subgroup where it does harm. If overall both the two groups are sort of matched, then you get a negative trial, where the patient in whom it does good outweighs the one in whom it does bad, you can get a positive trial. But when you actually use it on a patient, there is a certain subgroup of patients who might be harmed by that study, harmed by that particular drug, though the study was a positive trial. So actually you still need to individualize to try and find out in whom those patients, that those particular therapies might be more effective. That is the whole aim of now, personalized medicine is becoming, so this is, the steroids, CRP, etc., very simplistic, a very simple way. Obviously we need much, much better ways of defining who are going to respond, and that's what this whole thing about personalized medicine is all about. Trying to, further crystallize, find out, getting it, like statins. Now everybody with high cholesterol gets a statin. And we know out of the 100 people who get a statin, barely 2 or 3 are benefited. But you need to further refine and find out which is the subgroup of patients with high LDL cholesterol where statins fit the most good. Only then should you, so gradually with more and more research, we'll be able to come down to the numbers whom we actually give the drug. But we need, the same theory applies in, applies in critical care. You need to be able to refine and find out exactly the number of patients in whom a particular drug, which has been shown in a larger trial in a heterogeneous group to be effective, whether it is, which particular patients need it effective. So these are some of the terminology. This is borrowed from Sumit. So phenotype, basically, we know like ARDA, septic shock, AKI, etc. are phenotypes. Subgroup is within the phenotype. A subgroup is one particular, just one, like you say, somebody with a low PA to FI is called a subgroup. But a subphenotype would be you take a 3 or 4 or 5 or more, just not just one characteristic. You take 4 or more, then you call it a subphenotype. Then endotype is basically, you find out that a particular subphenotype responds to a particular treatment. Then you call that a particular, endotype, and treatable, that's, it may or may not be associated with treatment. Treatable trait is that particular endotype is associated with a particular treatment. So that's the, so these are the so these are all the ways in which you can, now comes to all the tough part, which I have completely skipped over because most of this I can't understand. And anyway, at the moment, pretty sleepy and tired, so I think you'll have to forgive me for. But this is an interesting talk. This is, of course, we know this study because this is from the ARDS net, which looked at the pro-inflammatory, they looked, phenotypes, the pro-inflammatory, they looked at several markers, and they find out the divide in the pro-inflammatory and the hypo-inflammatory phenotypes. And they found that the pro-inflammatory phenotype responded probably better to higher PEEP. They responded to simvastatin. They responded to fluid restriction, whereas the hypo-inflammatory phenotype did not. They actually were harmed by higher PEEP. They were harmed by, not harmed, but did not much good by simvastatin, and probably were okay with liberal fluid. So this is one of the earlier studies where maybe you could use it at the bedside, but still, even there in typing the hypo-inflammatory to pro-inflammatory, they used a lot of variables which are difficult for us to measure in the ICU. But now I think they're doing a study where they're going to take 4 or 5 of those easily measurable, markers and probably make it easier for the clinician to decide whether the patient is hypoinflammatory or hyperinflammatory. This is one study which might be coming into, practice in the near future. This is another nice study from, again, Sumit's study, Sumit's slide. We divided them into 4 different phenotypes and basically alpha, beta, gamma, delta, and depending on them, they're basically the different, responses to the sepsis. So basically on this, you could decide, at least you could prognosticate and find out, how to, who are the worst patients. And this study basically showed from the, why patients with a particular phenotype, they use steroids. And they found the differential. Now, the interesting thing is that in ARDS, they looked at the phenotypes as hyper, but the same principle applied to other conditions in the ICU, like pancreatitis, sepsis. The same phenotypes probably have the same responses, though they were studied in ARDS, probably the same. So like in cancer, now we realize that sometimes in cancer, it doesn't matter where the cancer is, it depends on the molecules that they have, the genes that they have. The treatment would change depending on, so similarly for in the ICU, it may be ARDS, pancreatitis, polytrauma, burns, whatever. Not polytrauma, they are SRS, but other conditions, maybe the location may be different, but if the phenotypes are the same, maybe the treatment would be the same. So that's the important thing. And here, this probably explains why there's so much of controversy about steroids in sepsis, because there are different phenotypes. Some phenotypes are benefited by steroids, some phenotypes are not. But at the moment, we don't have CRP, like I told you, is a very crude clue, but we need better ways of a clue of finding out who are the likely to respond to all this. So these are all the ways in which you can do, like I said. And finally, this is the promise of personal care and of intensive care. Our patients will benefit when we develop this is not mine, this is the statement. So we develop on how the person can affect their care. Critical practice will improve as a result of systematic application of the understanding to optimize outcomes for each patient. The best approaches will maintain individualized care and so on and so forth. So at the moment, how would I use personalized care? I would not blindly follow any trial. I understand majority of patients you probably mind, but sometimes you need to ask when you need to, overlook the trial. So like personal nutrition, somebody you don't have to jump to nutrition. Everybody, patient is well healthy. You don't need to jump to TPN or enteral nutrition day 1, day 4, 5, even day 7 in a healthy patient. I don't bother, I can still keep them NBM. But somebody who's malnourished to begin with, obviously I would be a little more concerned. So similar, I mean, this is one of the things that I do. Anyway, thank you. I think that's enough for, thank you.